Hello, and welcome to this PAH Initiative podcast. This podcast is sponsored by, and the presenters are being compensated by United Therapeutics. In this series of podcasts, we will talk about how PAH treatment guidelines and risk calculation drive treatment decisions in PAH, as well as our own experiences in treating our patients with PAH. I'm Dr. Vallerie McLaughlin.
And I'm Dr. Raymond Benza. It's a real pleasure to be here with my close colleague, Dr. McLaughlin.
Ray, it's always a pleasure to work with you. I really enjoyed our first podcast, during which we discussed the importance of risk assessment in PAH management. In this program, the second in our series of podcasts, we're going to discuss initial therapy choices based on risk assessment. So let's get started with that. Ray, let's say you've just met a patient, you've just diagnosed a patient with PAH. How do you determine their initial treatment plan? There's so many things to consider and so many agents that are now available to treat PAH. What's your approach?
Well, I agree with you. I think that's one of the nice thing about treating pulmonary arterial hypertension in this era is that we do have so many available agents to treat this disease. As you know, when we both trained, there was only one therapy for this disease, and now we have at least 12 to choose from. So understanding how to use these medicines intelligently to both make patients feel better, function better, I think is really important. And I think the common ways that we do that now, as we talked about in our first podcast, is to really use a multidimensional approach that evaluates a person's summated risk and then base our treatment therapies based on that summated risk. Whether you use the Reveal calculator or one of the European systems, this multidimensional risk paradigm is really very important. And I think the guidelines say that most patients who are judged low or intermediate risk should receive upfront oral combination therapy, and that those who are at high risk, conversely, should really receive combination therapy that includes an IV prostacyclin class therapy. And then again, as we mentioned in our first podcast, our treatment goal is really to get patients to low risk and then monitor them continuously. And again, always reassessing, always trying to drive them to this low risk goal, because we know that that improves not only mortality for these patients, but also makes it a much less morbid disease. They're functioning better in their own home environments.
Yeah, I think that was a great summary, Ray. So I agree. In my practice, probably a very small proportion, maybe less than 10% of patients are at such high risk when we make the diagnosis that they go on to parenteral prostacyclin therapy as part of their combination therapy. The vast majority of patients are intermediate risk, and there are some low risk. And we use upfront combination therapy, generally with an ERA and PDE5 to start out with in most of our patients. What's your practice, Ray?
I agree with you. I think we need to be very careful in this category. One, because we know that PAH is a progressive disease, and we want to make sure that we halt this disease in its track. And just the combination of several medications really seems to do a good job trying to really slow down the disease. But as you mentioned, there are a few people who can be started on monotherapy, and I believe these are the people who are extremely low risk. For example, having 4 of low risk factors by the European methods, or a Reveal score less than or equal to 5. These people usually have a low risk both of morbidity and mortality, and may be an ideal patient to use monotherapy on. But again, I want to caution everyone that when you use these multimodality risk factor parameters, as we mentioned in our first podcast, you should use these together both with your clinical gestalt and with other modalities that are not defined in these contemporary risk stratification systems, particularly imaging of the right ventricle. So if I see someone who's low risk, but their right ventricle is still not looking good, that's not a patient for monotherapy. These are people who usually have really well-preserved right ventricular function. They're low risk by these contemporary scores, which includes a low functional class, a low pulmonary vascular resistance, a low mean pulmonary artery pressure, and as I mentioned hypertension and stressed, a normal right ventricle at echo. And we have had people who've been treated with monotherapy for more than 5 to 10 years on a long-term basis and are stable with a low-risk profile. But the key is here, you have to continually reassess to make sure that these patients that you're treating with a singular drug really stay low risk in the long term. So again, constant reassessment, as we talked about in the first podcast, is really really very important. And then obviously, as you mentioned, Val, when combination therapy is either unavailable or contraindicated because the patient may have severe liver disease, as an example that you get, may be an indication for that. Therefore, monotherapy is really the exception and not the rule.
Yeah, I think that's a really wonderful summary, Ray. I just want to focus a minute on those low risk patients. We're still recommending combination therapy on low and intermediate risk patients, with the exception of, some of these patients with extraordinarily low risk status that you described. Those patients, at least in my practice, are few and far between. Ray, what's your experience?
No, I agree with you. And that's why I really want to issue this word of caution to be really careful that you really scrutinize this low risk to the highest extent that you can, because you don't want to do these patients a disservice. Just was going to agree with you, Val, that, my experience, actually very, very few patients are in this very low risk status, as you mentioned. So caution, I think, is the key word here.
Yeah, I would say the patient population that I tend to see in that very low risk status at the time of diagnosis are those patients who are very aggressively screened in our scleroderma clinic, and they get diagnosed with PAH with a mean pulmonary artery pressure in the low 20s and a pulmonary vascular resistance of, just barely over 3 with a normal right ventricle. Don't see them that often, but that's the group that I tend to see them in. But let's say, Ray, you diagnose a patient, you start them on a treatment plan. We have really emphasized the goal of getting them to a low risk status. How do you monitor them? What's your approach to reassessing them for that risk status, and how do you approach the continued management after that first initial treatment decision?
Well, as we mentioned, Val, and you and I had this really great discourse in that first podcast. Really achieving the low risk status is our goal. And this is supported by multiple registries looking at thousands of patients. And we know that people who achieve low risk status live longer, function better than those who remain at intermediate or high risk. So that's something that's always got to be in the background when you're evaluating these patients on a continual basis. And that, again, is the really key piece here. These are patients that you just can't start them on a medication and walk away with them. They need to be constantly reevaluated, constantly risk stratified. And as we mentioned in our first podcast, using very simple algorithms like the European low risk criteria or Reveal Light 2, which has very simple to garner modifiable factors, we can really risk stratify them every time we see them in clinic, or even over the telephone in some instances, to make sure that their trajectory is following the path that we want them to. But certainly we want to officially see these patients after starting them on new therapy, certainly within 3 to 4 months, to do a good risk assessment, probably using an imaging modality in addition to the contemporary risk stratification systems that we do. Some people, if they're moving really aggressively in the wrong direction, could add another set of hemodynamics to that, again, to reassess the patient in totality to make sure that we're pushing him in the low risk status. And if we're not, then we need to intensify therapy to really get them moving in the right direction.
Yeah, I agree with that, Ray. And I just want to emphasize one point, and that is the timeline. I would have to say that my practice has evolved to be a little bit more on the aggressive side. We do a nurse practitioner virtual visit at 1 month just to make sure they're tolerating the therapies well. We find that helps with retention on therapy. We can talk them through some side effects. And I'm now really leaning towards that 3-month time point to bring them back into the office and reassess their risk and decide if we need to escalate therapy. So I think that is really important, as you've emphasized. Get them to low risk, and I think it's 3 months. 4, I think 6 is stretching it. But let's move on to aligning goals. We're physicians. We have studied this. We have this vision of improving long-term outcomes of our patients, and we know with all the data that you have reviewed that getting them into the low-risk status improves their outcomes. But really, what the patients want is to feel better, right? They come to us dysmic. They come to us not being able to go up the stairs. What they want is to feel better. They want to feel less short of breath. They don't want to have a lot of side effect medications. We really need to align our treatment goals with the patient's lifestyle goals and their goals for their everyday, day-to-day living. Can you tell me a little bit, Ray, about how you incorporate that in your practice?
Yeah, Val, I think, of the many things that we talked about today, this is one of the most important aspects of therapy that is often neglected. Patients have to be involved in your decision making at every point. Physicians at times get too focused on mortality and morbidity, and really what the patient want is, as you mentioned, they want to feel better. They want to breathe easier. So incorporating these symptoms in your treatment paradigms are really important. And we use simple tools like the emphasis questionnaire, or even sometimes even more complex questionnaires to really get a good idea how the patient's really in functioning and feeling in their own environment. And we use these quality of life measures in determining how aggressive we need to be. Is there a balance between side effects of medications when they're on combination therapy or when they're not really feeling well because of side effects? So you really have to take the balance of how a patient feels from a quality of life perspective in the intensity and aggressiveness of your medical management.
Yeah, I think that was well said, Ray. And I think it's really critical to involve the patients. I did a video visit earlier today on a 19-year-old gentleman with heritable disease. He's not where we want. And probably one of my most important questions to him is, tell me what you want to do that you can't do right now, and setting those goals, trying to figure out what it is the patients wants in their lifestyle and how to balance that with the side effects of the drug. So that's, it's really critical. And I would also want to emphasize that this is a tremendous opportunity to involve the rest of our allied healthcare professionals. Many of these medications have side effects that are complex to manage. And sometimes patients give a little more information to nurses and nurse practitioners than they do to physicians. And I feel very fortunate, and I suspect you are as well, Ray, to have such a wonderful team of nurses and nurse practitioners who really are partners in managing this disease, particularly when it comes to the lifestyle issues of the patients.
Yeah, Val, thanks for bringing up that very important point. I really love the idea of patients articulating their goals at the beginning of therapy, and the incorporation of all the wonderful allied health professionals, as you mentioned, into this decision tree, so a patient really feels taken care of as a total person, I think is really important in setting the trends for their long-term therapies.
Well, Ray, it's always a pleasure to chat with you. I enjoyed our podcast today on this very important topic of therapy choices and risk assessment. I'd like to thank the audience for joining us today for these discussions as well. Join us the next time to discuss monitoring patients over time and considerations in escalating therapy for patients who are not at low risk.
If you would like more information on risk assessment, PAH treatment guidelines, or to use an online risk calculator, please visit pahinitiative.com/HCP.